Hello and welcome in today's nursing webinar session. Myself Shanti, and we are going to discuss about the concept of VAD'S, which is nothing but vascular access devices, its handling methods, and care and maintenance. So I think Dr. GVK Garu, who is Dr. G. Vamshi Krishna Garu, is going to join us. He's from Malakpet Yashoda unit. He's our senior consultant medical oncologist. We'll just go on with our session. He'll be joining us. And let me also welcome our very dedicated and senior patient safety officer, who is none other Miss Shantha Kumari from Yashoda Hospital, Malakpet branch. As we know, we can start the session. Shanti, share your slides. We are going to talk about the VAD'S, which is vascular access devices. And as this topic is not very much known to all the nurses, especially nurses who are working in the medical surgical wards. So this is known as central venous access devices. There are many central venous access devices in terms of many catheters and invasive catheters, but two of the major points which we will be talking about is PICC, which is peripherally inserted intravascular catheter, and the CHEMO port, which is none other implantable port. Yes, you can share. So the nurses in the ward, sometimes we see them facing a lot of problem when in sudden evening the VAD is blocked, and when one of the catheter is blocked. What they are going to do, who they are going to call, whom they are going to call in the scene, that all we are going to discuss in this. Let us see the first definition. Shanti, you're ready? Yes, you can go with.
A very good afternoon, Vananda. I am Shantha. Let us discuss about what is VAD'S. VAD'S is nothing but vascular access devices. The vascular access devices like PICC and port are used for long-term access. These devices are classified as either a peripheral or central access devices, as shown in the images PICC line and CHEMO port.
Yes.
Let us discuss about why VAD'S recommended. The VAD'S recommended for clinical needs of the patient, the type of IV therapy or treatment required, and anticipated long-term chemotherapy and administration of IV antibiotic. Can do administered through VAD'S, long-term chemotherapy, medication infusion, administration of IV fluids, blood sample collection and blood transfusion, parenteral nutrition like TPN, dye for radiological investigations like PET and CT scan, and dialysis.
Yes. So, Shanti, can you just go back to the third slide? Go back to third slide. Yes. Here we would like to tell to all the viewers, if Shanti has just spoken about anticipated length of therapy, it means the clinical need of the patient will be first selected by the consultant, and then the course of treatment. As you know, Shanti has just told that anti-cancer regimens are given through these ports, not only drugs, even infusions and other sorts of infusion as well. So this anticipated length of therapy also will be kept in the mind. Then these ports or PICC lines are inserted. Yes. Come to the fourth point. Yes, as you know, parenteral nutrition, because the parenteral nutritions will have high osmolarity chemical contents in that. So for this, we require the big bore of these catheters. So this selection also is always right. And medication infusions, and you all know chemotherapy drugs are very vesicant in nature. So we require this kind of VAD'S for the patient who is going to have the long-term therapeutic need. Yes, you can go with the first slide.
Let us discuss about what is PICC. As we know, PICC is peripherally inserted central catheter. It is inserted into a peripheral vein in the upper arm at different sites like basalic, cephalic, or brachial vein. These are the areas of placement.
So here, yes, I would like to welcome our the expert panelist, Dr. G. Vamshi Krishna Garu. Sir, I welcome you here in this session.
Good afternoon.
Good afternoon, sir. As we have spoken a little about the indications of why patients will require these devices, and as we see this, definition just now Shanti has spoken, compared to the first, question we would like to understand from you is compared to other methods of access like IV and all. What is the importance of these devices, sir?
So mainly, I think most of the patients whom we are admitting in the hospital will require an access device. So I think all of us have noticed that nurses usually they try getting a line when the patient is there for a long time, and we have few patients whom the access will be very difficult. And I think these access devices are a boon for most of these patients who require long-term catheterization, long-term cannulation, because mainly for the medicines administration. And more so, I think the specific lines which we are going to talk about today, I think the PICC line or the ports, all these devices are usually maintained for a year or so. So we don't have any peripheral cannulas which can last that long. So I think we have the innovation with these new products which have a very beautiful material which lasts for a long time. So only we need to know is when we need to insert these lines into the patient, because there's no point in pricking 100 times and trying to get a line in the jugular, probably femoral on the legs. So I think we need to act before, because ultimately the most important thing is the patient should not be having a bad, unpleasant experience with the nurse pricking so many times for access. So the first thing which we listen from patients, sir, we had so many sisters who were pricking us since morning for getting just a blood draw sample for the testing or for a IV medication. So what as a nurse, which probably I think most of you might agree is, you don't want patients to curse you. So you want them to be very happy when they are seeing you. So I think these devices really help us. Probably I think you can draw a sample from these lines and probably administer medications for how long ever the patient is there in the hospital. Only one important thing which you need to understand is how to use this line safely so that you don't spoil the line. So what is the term spoiling? Is either you cause a blockade in the cannula or you push an infection inside.
Yes,
so these are the two things which we need to be very careful, which we'll be discussing in the coming slides.
So over to you, Shanti, for further more discussions. We'll have intermittent discussions and question is from sir. Yes, go on.
Let us discuss about what is CHEMO port or implantable port. A implantable port is a central venous access, a device that is attached to a vein. It is placed in upper chest underneath the skin. It is designed to permit repeated access.
So, sir, are there any potential drawbacks for these implantable port? And because I think you're the only one person who will convince the patient, because their emotional and psychological aspects also does matter for us, because easily they cannot just go for these devices. And just because we have very fresher nurses over also who are viewing this webinar, sometimes they might shift this patient to MRI or PET-CT. Are these devices are MRI compatible as well? Okay, I think there's any problem. So we'll just go on. You can just go to the 7th slide. Sir might join us here. So now we are going to discuss about onco nurses, very crucial. Go to the 7th slide. Yeah, very onco nurses, a very crucial role in handling, as the topic itself said, handling, care and maintenance of these devices. Shanti, you can just read the points. Yes, sir.
Sorry, I think there was some issue with the video.
No problem, sir. Go back to the 6th. Yes, sir.
We were talking about the central access device, the long-term access devices. I think we discussed about the PICC line and the port.
Yes.
So I think, as you rightly said, how do we convince a patient for a PICC line or a port? So if you can see, these are two different lines which should not be compared in the comfort. So we usually decide either for a port or PICC line based on the patient's preferences most of the time. And if we compare these two lines, a port can be maintained for years. So if you are looking at someone who is going to be on treatment for probably a longer time, I think port is something which will be suggested. And a PICC line, usually if we are managing it really well, I think the longest we see is 6 months to 1 year is the average time which we can maintain this. So the port and PICC line depends on the patient's preferences, the first thing. Second is how long we need to maintain this line. So there are few patients who might require chemotherapy for 2-3 years. So for this patient, we usually don't suggest a PICC line. Port is better.
Port, yes.
Third, for a port, we need to do a small surgery where we'll have a small incision on the upper chest, where we put a device here, and from there we cannulate to the central vein. So it requires a small surgery, which probably few patients may agree, few may not agree. So all this, again, as I said, it's a discussion which patient should be having with the doctor. And the main ultimate thing which the patient has to understand is both these devices are for repeated access, both for the blood drawing and for pushing medications. So in my opinion, I think what we have to see is the comfort of the patient. So if the patient asks, I don't want surgery, I'm comfortable with a sticker on my hand,
PICC, yes.
for a PICC line. And if the patient is stable and patient understands that they need to go for a treatment for a longer time, we suggest the implantable chemo port.
So these are all MRI compatible, no, sir?
Yes. I think all the PICC line does not have any metal component, so it's MRI compatible. Only thing what we have to understand is for the PICC line, we have the power PICCs and the normal PICC line. So the patient has information about the line they have been inserted with. So normal PICC line, we cannot give the IV contrast in the CT or MRI. The device power PICC is another PICC line which can be used for contrast administration. So most of the times we use the conventional or the normal PICC line, which should not be used for contrast administration. But I think we have few patients whom we have inserted the power PICC. So the doctor will be deciding whether the contrast can be given through this or not. So why is contrast so important? So if we are giving any CT and the contrast, the pressure with which we administer it is very high. So the normal PICC line will not handle the pressure and there might leak, rupture and leak. But the power PICC is designed to handle the same pressure. So we can administer the contrast safely through that. The same thing holds for the port. We have power ports where we can administer contrast through these ports also. But again, conventionally for majority of them, we don't put this mainly for the cost difference. It's only a couple of thousands more. So if our patient has this port or PICC line which are compatible with only contrast, we give through that. Otherwise, all the PICC lines and ports are compatible with MRI and all scans except contrast administration unless specified.
So very valid point, which I myself didn't know. I think this is very valid point, and all the learners and viewers should make note of this and shift to prior and discuss with your consultant. Yes. Next point.
Let us look into the crucial role in handling, care, and maintenance of VAD'S. Skill and senior nurse must be competent enough for handling and care of VAD'S. Always use aseptic technique, hand washing, wearing PPE before and after clean the hub are very important. Site assessment to be done by every shift by all nurses. Assess these sites regularly for sign of infection such as redness, swelling, warm or ooze. If any present, document immediately and inform to the consultant.
So, sir, here again, this is very important slide which we always wish to know. If at all the nurse while her handover, if she sees this redness as a very single factor for the infection, what further more precaution can she take, or she can just continue with the infusion, or she should just wait for your intervention or your team's intervention? What would be your take, sir, for the nurses?
Yeah, I think so. We are talking about the PICC line entry site assessment. Okay. So we have a PICC line entry, as you can see in this slide, the picture, there's a redness around the entry site. So probably this is a local site because the PICC line enters through a tunnel into the vein from the skin.
Yes.
We commonly see entry site infections, which is quite common. This may happen during dressing, or it might be colonization by the normal skin commensals. So as long as there is a good backflow and there is free forward flow with no fever or chills while administering the IV fluids, we can continue using the PICC line. But if there is any purulent discharge from this site, you can see the site around the cannula insertion site. So if you are seeing any pus, what you should do is just take a swab from that for culture sensitivity, and we'll continue the treatment as long as the patient is stable and not having any signs of systemic infection. So local infection, we are not worried. Local infection, what we usually do is, based on the culture sensitivity, we try to treat it with systemic antibiotics. At times, we may give the topical antibiotics like mupirocin or T-back, whichever we apply. We do the dressing for a couple of days. It should subside. So, but if there is a pus and hard induration along the course which is not subsiding, if there is an entry site infection, if you are giving any infusion and the patient has severe chills and fever, it is something where you should understand that the infection is much deeper. There we need to inform the doctor, and after assessment only we need to use the line.
So very productive insight, yes.
Let us discuss about monitoring and assessment of potential complications like catheter-related bloodstream infection. If we do not follow universal precautions, if catheter migration or any mechanical issues for pokes happen, then immediate action to be done is nurse should not push the VAD back in. It may require to be removed and replaced.
So, sir, I think sometimes we see this one fine evening, maybe the continuation of chemo is already there, and one fine evening the nurse contract this kind of scenario. What she should do as a first, step, like as it is mentioned, not to push anything. Obviously, she will escalate as well.
Yeah. So I think again, for this is not for the chemo port, because most of the times the chemo port is tunneled beneath the skin. So this is not a complication which we see with the chemo port. So this is a common complication which happens with the PICC line, where most of the times there may be breakage or accidentally the catheter might be displaced. I rightly said, most of the times patients we see the tip will be hanging outside.
Yes.
So the main purpose of this line is that the tip of this line should be in a major vessel. Why? If you are giving it in the major vessel, the dilution, the osmolality should be handled in the larger vessel than the smaller vessel. So if the tip is very much outside, so probably if it is way back in the arm, so we are seeing it in the basilic vein also, there is no point in having a device. So usually we get an X-ray to see how much is left inside the body and see whether we can continue using it or not. So as you rightly said, if there is dislodgement, the sister should not be afraid. Don't try to push it back in. That's the commonest thing which sisters try to do, because they fear that, okay, it might be blamed on them. So you should be telling the patient and try to counsel them that if you push inside, the infection might be even worse. So how much ever is left behind, let it be there. Try to fix it in that position and immediately call for help. Let the doctor see, and based on the tip of the catheter in the X-ray, we decide. See, if it is somewhere over here near the junction, I think we are still okay with that. A couple of centimeters, 5-10 centimeters, which is pulled out, can be managed in that position. Again, we fix it in that position. But if the catheter tip is very much outside, usually we remove it and try to put a fresh catheter.
So until these troubleshoot is taken place by the clinical, fraternity, can the nurse put peripheral line and restart the infusion, sir?
Yeah, I think there are few infusions which can be again restarted through the peripheral vein. Few infusions might require a central line again. So again, it depends on what the drug patient is being administered with. So what usually we do is, if the line is almost outside, we try to hold the further infusion unless there is a clearance from the consultant, and then decide for having an access device either in the peripheral IV cannula or again probably reinsertion of a central line or a chemo port. So this is a common complication of a PICC line, where PICC line migration is a very common issue which we see in our day-to-day practice.
Let us discuss most common trouble faced by bedside nurses are: if impossible insertion of injection, it failed, then nurses should check for occultation of catheter or port, kink in the catheter. In such cases, do not force the flesh It may rupture the line.
I think, sir, you may agree with this, whatever is being just presented. Yes.
Nurses' attention to detail when patients are with VAD'S. Observation should include while handover at bedside, insertion point and site, the site healthy, dressing it is always clean and intact. If any hematoma beneath chemo port, does the VAD show sign of leakage or fluid or air escaping, or the connections secure and sutured, and all the checks and action should be clearly documented and handed over to the next nurse.
So, sir, if we are talking about this infiltration or extravasation as a adverse, side effects of these implanted catheters or port, so the medication, vesicant medications remains the single factor, or the handling also must have caused, or something else must have contributed to this, which is very rare, but still would like to understand.
Yeah, I think for both the PICC line and the chemo port, each time we access it, we should be very clear that are we in the right place. So each time you put a needle in a port, so you might be seeing the same patient 100 times, but you are inserting a fresh needle. So always check the backflow, see that there is a free flow of blood in the syringe, and then try to push it back. And if there is a free flow, then only start the infusion. So most of the times what we see is a patient might be seeing the patient every day. Like what commonly happens is they will be giving chemotherapy on day 1. So
Yes.
day 2, the needle is inside only. So the patient might have moved somewhere. So they, again, the next morning, the patient comes back from home or so, they directly start the infusion, and then these accidents happen of extravasation also. So whenever you are accessing a patient, each day, see the backflow and then only start the infusion. So I think that's the rule which all the nurses should follow. Check the flow, backflow, then only push. Yeah, if there is any pressure resistance to your forward flow, check for any kink, check for any block, then only push it. So you should never push hard. It's always pull hard. It does not matter. Don't push hard.
Yes.
Flushing practices are very essential for all nurses while handling lines. Regular flushing of these lines are crucial to maintain patency or prevent occlusions. For flushing, always use sterile saline, heparin lock before and after medication administration, as well as during routine infusion like blood transfusion. Concept of how to flush the line. Always use big syringe like 20 ml or 10 ml syringe. Do push and pass technique to create a positive pressure. We have to maintain always positive pressure in the line and flush after every use. For example, blood draw and blood transfusion after administration of medications.
So I think keeping these devices patent is the single most best practices which lies with the nurses. I think you will also agree, and I think, sir, maybe adherence to this flushing protocol is only one preventive factor for catheter not getting dislodged.
Yes, rightly said. I think putting a line is very easy, but how we maintain it with regular flushes and with strict asepsis is very important, because each time you use a flush, each time you use an infusion, each time we should be very careful. So that's the only one mistake by one nurse can spoil the good work of all the 99 nurses who have handled the line for a long time. So
Exactly.
each nurse should understand that these are very sensitive things which we need to understand. It's not like someone scolding you or telling you this is not done, but it should become a protocol in your day-to-day practice that it's something which is in the major vessel and it needs to be handled with utmost caution and a strict asepsis. So what we usually see is, yeah, first time they are very careful, but for a flush, okay, it's only a flush. They try to be callous at that time. So they do all the work great till probably 2 days or 5 days, and one nurse spoils by giving a contaminated flush, and that causes infection, and we have to pull out the line. So handle each time with the same sincerity and discipline as you were handling it on the first time.
Yes, very rightly said. Yes.
important nursing precautions. Do not tie and check blood pressure for PICC line arm. Before removal of device, assess patient bleeding risk. Carefully remove the dressing in an upward direction toward the exit side, not to pull the catheter, and apply pressure immediately to insertion site until hemostasis is achieved.
Any other precaution I think we should take for the patient post removal of these devices, sir?
I think if you are removing the PICC line, I think it's just administer pressure for I think couple of minutes. I think that should be. It's just like what you do for IV cannula. So
Yes.
you need not worry much about the pressure for a peripheral inserted PICC line because it's also on the superficial thing. You just apply pressure over the arm. It usually causes hemostasis within a couple of minutes. And the same thing will apply for a port needle because we are not using any pressure on the major vessel. It's only the superficial skin bleed which we are going to stop. So the hemostasis is easily achieved both for a chemo port and a PICC line when you are removing the needle from the port. So it usually, I think the pressure should be hardly for a couple of 10 to 30 seconds is what we usually suggest. Beyond that, just put a pressure bandage and leave it. Yeah, I think the hemostasis for removal of central line is much important because there we give pressure for a longer time. These lines do not need pressure for that long time as we do in a central line removal.
Before going to discharge, we have to educate the patient about care of VAD'S at home. Always observe the site, kept clean and dry. Cover with plastic sheet when shower for patient with PICC. Avoid heavy lifting objects, arm stretching, etc., etc. Do not sleep on the site of port, not to bend the arm. Notify physician if any complications like pain, fever, swelling, etc. Weekly dressing or when visibly loose or soiled and flushing of PICC line. Monthly flushing is required for chemo port. Thank you, ma'am, for giving this opportunity.
Okay, so we have come to the discussion, end of the discussion, sir. I think you will also, I think these are all the best suitable guidelines which you all have designed for the patient. Any other points we must have forgotten to add in this, PPT or anything else you would like to quote?
Yeah, I think we should tell the patient that feel normal because what we see is, I think the more caution we tell them on the side where the arm is inserted, we see them ending up with arthritis on the same side. Shoulder arthritis is what we are commonly seeing. So what we usually suggest is, yeah, you need not play cricket or do heavy objects, gym on that side, but at least the normal activities can be done in the same side arm. And whether to sleep on the same side of the port, I think this is one controversial thing. I think probably most of the times we try because bending the arm, we usually put the PICC line much above, so it is not affected by any bending.
Okay.
So I usually see that it is not crossing the flexure, so the patient can have normal range of movement. So imagine putting a line in a patient and asking them to not use it for 1 year. It's
Yes,
going
yes.
to make that arm vestigial. So
Thanks for
I
your
think,
correction. Yes, sir.
yeah, I think the port or PICC line try to be as normal as it was earlier. You can bend your hand, do your normal activities. Yeah, I think rest all I'll agree. I think probably we need to be very careful if the patient has any fever or pain at the site. We need to understand that it can be PICC or port line infection. And most of the times the responsibility of maintaining the PICC line is with the patient and the nurse. But for the port, it's entirely on the nurse because I think that its access is everything by the nurse herself. So I think we need to be more careful when we are handling the chemo port. PICC line, at least you have something to say that, okay, the patient did not come for follow-up visits for maintenance of the PICC line, but port, we don't have any of those excuses. So be very careful when you are using both the PICC and port line. Try to talk to the patient as frequently as possible whenever you're using. And as I said, don't get complacent with the patient or with the line. So see that you respect the line each time more than the patient.
So, sir, on your rounds, do you witness any very such common challenges when the ports are implanted? And hereby, we would like to correct all the nurses who are watching this webinar.
Yeah, I think for the PICC line, what we usually see is they usually, as I said, the handling and the flushes, I think the first time they usually use the gloves and the strict precautions, but during the period of hospitalization, they use it as a normal IV cannula,
Yes.
which is not a good sign. So I think each time you access it, please use the same precautions as you are doing. And second thing is, when we are using the flushes, see the fluid we are using, because most of the times the flush we use is common for all the patients. So it might be contaminated if we are using the same flush for a PICC line or a port patient. Try to have a separate IV bottle which you
Flush,
use
yes.
for flush for these patients. And I think for port, most of the times it's all the sealed devices which we use. The Heplock comes in a sealed vial, so we suggest using the same one as a flush. And the insertion, I think you need not be afraid. These are not something from Mars or somewhere. They're very simple lines. It does not need lot of training. It's just like what you access a normal IV cannula. Only thing is just be worried about the asepsis technique. Because insertion, everything is taken care by the doctor, everything is checked, then only you are allowed to handle it. So just try to maintain it with strict asepsis and you will have comfort because you don't need to worry about calling the phlebotomist for picking up the blood samples or calling the anesthetist if you have difficult access. So you are that job of getting a difficult access is almost solved with these lines. They're wonderful devices. Yeah, I think in the future we might go for the lines, the power picks, where probably even the contrast also can be easily administered through these lines. And I think it's only because the shortage of the systems we don't use them so frequently. So I think we do have these occasional patients who are suggested for these patients because we cannot even get a single IV cannula in these patients, like those patients who have bilateral mastectomy. These patients we go
Yes.
for power ports only.
So thank you, sir, for a very beautiful and productive insight you have provided in a very simple and concise manner. And we urge all the nurses to follow what has been discussed in this forum. Thank you, Shanti. And we end the session. Thank you, sir.
Thank you. Thank you, Shanti and Shantha Kumari.
Thank you, sir.
Thank you, sir.